Okay, so chapter 11 is immunizations and immunosuppressant drugs. So the immune system in general can sometimes seem confusing because it's not like one specific organ, it's a whole bunch of different organs that work together. The immune system parts can be found in lots of different places throughout the body, like near areas where invasion and injury are more likely to happen. Okay. The white blood cells involved in inflammation are the neutrophils, macrophages, eosinophils, basophils, and a tissue-based cell called a mast cell. The B lymphocytes and T lymphocytes together are responsible for providing long-lasting true immunity, so that for most types of diseases caused by infectious organisms, you only have the disease once. So immune responses are not automatic, okay? They are a learned internal protection. They occur through the process of getting antibodies, antibody formation. So all white blood cells can recognize an invader. And the white blood cells involved in inflammation are the best at it. Once a foreign or invading cell is recognized, the general inflammatory cells take steps to eliminate, neutralize, or destroy it. So at the bottom of page 188, there's a little picture that has like the invading cell, the immune system cell, and all the self cells, and they have like barcodes on them. And that might sound silly, but that's kind of what it's like. So the immune system cell is going to, quote, scan the barcode of all the other cells, bless you, all the other cells around it. And if it recognizes it as a self cell or a cell of the body, it'll leave it alone. It's good to go. But if it recognizes it as an invading cell or a non-self cell, then it's going to work to eliminate it, neutralize it, or get rid of it, destroy it. Yeah, Taylor.
I was supposed to be filling these out.
Those are your own study tools.
But for data said what? Like the medicine, a certain
For the drug classes. So, and we can look at that more or talk about it more after class, but in each of the, let me see what boxes. So in each of the drug class boxes, they're green, like it'll say the drug class and then all the drugs in it, and then you fill out the paper accordingly, but we can talk more about it after. So some of these white blood cells bring the invading antigen into contact with fresh, unsensitized lymphocytes. The sensitized B cell is then going to start making and releasing antibodies that will only bind to cells or products that carry that specific invader's code. So if the immune system cell learns or makes an antibody for the invading cell of, I'm going to say COVID, because COVID's a good example. Next time COVID comes into the body and the immune system cell scans the barcode, right, in quotes, it's going to say, oh, that's COVID. I know how to fight that. And it's going to send out the response to fight it. Hopefully before we even realize that there's an infection. When you're re-exposed again to the virus, this could be COVID, it could be chickenpox, whatever, later in life, even when the exposure is huge, you will hopefully not get sick because those sensitized B cells have produced enormous amounts of anti-chickenpox or anti-COVID antibodies. So this means that antibodies go where they're needed most in the body, like the site of invasion. Also, because the antibodies are released into the blood, they can be taken from the blood of one person and injected into another person. So we have naturally acquired immunity. That's what we've been talking about, okay? Both types of acquired immunity can be divided into active immunity and passive immunity. I'm talking about naturally and artificially. So you'll have natural, active, natural, passive, artificially active, and artificially passive. All subtypes are helpful. They provide some protection, but they differ in how well they protect and how we got it. Naturally acquired immunity is when the body develops the antibodies. Naturally acquired active immunity is when the cells learn to make antibodies against invaders, okay? Like we were exposed to the disease. Naturally acquired passive immunity is when the antibody is transferred through the placenta or breast milk from mom. And then our artificially acquired. Artificial active immunity is when we deliberately put an antigen into the body to force our cells to make an antibody. Vaccines, yep. I know, but it's here too, so. These are less effective. They're needed more often. They're not permanent, but they're helpful, right? And then our passive artificial. I don't think there's a separate slide on the passive artificial, but passive artificial is when we take antibodies out of someone else and inject the actual antibodies, okay, into another person. The body does not have to make antibodies at all. It's passive. I added this picture because I think it's a good visual, okay? It's on page 190 in your book, but it's not in your original PowerPoint. So again, vaccines. Vaccination is the deliberate injection or ingestion. Sometimes we inhale or swallow a vaccine of an organism or other antigen for the intended purpose of stimulating B cells into producing antibodies that are specific to that antigen. The result is an immunologic resistance to any disease caused by the antigen. We have different types of vaccines. Inactivated vaccines are when organisms are killed, so they no longer cause disease, but it's still a version so that when we introduce it to the body learns how to fight it. Attenuated vaccines are modified versions of the live organism. Again, they're not capable of reproducing or causing disease, but they still have that organism's code. The toxoids contain a modified toxin or part of an organism. They have the unique code to stimulate proper antibody production. Biosynthetic vaccines are science-made substances that are similar to the parts of a virus or bacteria, so that the body learns how to fight it if it's introduced to the real thing. And then we have mRNA. These are lab-generated pieces of genetic material that code for making a specific part of an organism. Currently, mRNA vaccines have only been developed against COVID. It's a new technique. It's likely to be used more widely for vaccine development in the future, but right now only COVID. For most types of vaccines used for artificially acquired active immunity, more than one injection is required on a specific schedule to ensure that adequate numbers of B cells become sensitized to the antigen and begin making those antibodies. For example, infants are usually vaccinated against diphtheria, tetanus, and pertussis, or DTaP or Tdap, however you see it, with a single injection. It contains all three antigens, and you get it at 2, 4, and 6 months of age for a total of 3 separate injections or doses. Recommended vaccines for adults against certain childhood disorders are going to vary depending on whether the person actually experienced any of the diseases as a kid. Some adult vaccines are recommended yearly, like the flu vaccine. Others are a 1-dose, 2-dose, or 3-dose lifetime schedule. On page 192, there's a box that has your responsibilities with vaccines. As a medical assistant, 192. As a medical assistant, are you going to be giving vaccines all the time? Yeah, that's one of your big job responsibilities. Then we have what we call an antibody titer. Okay, this is a measurement, T-I-T-E-R, titer. This is a measurement of the presence of antibody in your blood at different blood dilutions. So if you are not sure if you ever got vaccinated, or if you got vaccinated a long time ago and we want to know if you're still immune, we're going to draw a titer. The titer is going to tell us how much of the antibody you have in your blood. Do you have enough to be immune? Or do you need a booster? Then that artificially acquired passive immunity through the transfer of antibodies from one person or animal, or from lab-generated antibodies, only gives a very short-term immunologic protection. This immunity might prevent the disorder or reduce the disease severity. We saw these antibodies a lot being given in COVID. So someone has COVID and they are really having a hard time with it, or they have lots of other diseases or illnesses that could give them major complications. So we would give them antibodies that we did from, took out from someone else to help fight that. But it is not going to continue to give them immunity. Okay, it's just for like a one-time help you in the situation you're currently in. Artificially acquired passive immunity can also be used to prevent problems that are not related to infections. So if a person who is Rh negative is exposed to red blood cells that are Rh positive, their immune system will start making anti-Rh antibodies to get rid of the Rh positive cells. So we have what we call RhoGAM for pregnancy. The first pregnancy usually does not result in many of these antibodies. The first child's not affected. However, if mom becomes pregnant again with another Rh positive baby, remember mom is Rh negative, she becomes positive pregnant with an Rh positive baby, she makes lots of other antibodies that can cross the placenta and destroy the fetus's red blood cells, cause major problems, even death for the fetus. Okay. So remember, mom is negative, Rh negative, first baby is Rh positive. So mom is exposed to Rh positive and starts making antibodies. Doesn't affect first baby because she's making antibodies. Second baby comes along and is also Rh positive. Mom's antibodies say, oh no, I know how to fight this, and then fight the new baby. Okay. It can cause the fetus to die. It can cause death shortly after birth. It's a major problem. So we give RhoGAM to prevent it. So lifespan considerations for vaccines. Childhood is a time for extensive vaccination. Okay, our little ones, I felt like every time I took my son to the doctor for the first couple of years, he was getting a new shot, okay, a new vaccine. It's also when the recommended schedules must be closely followed for best effect. This is because the child's immune system is busy making antibodies to the organism that causes sickness. It might not be capable of generating those sensitized B cells and antibodies introduced with the vaccine. Although vaccine and immunization is best performed before pregnancy, some vaccines can be given during pregnancy. Now we're on the pregnancy and lactation, sorry. The flu vaccine is actually highly recommended during any stage of pregnancy. It's also recommended that during each pregnancy, the woman receive the Tdap vaccine. As a person ages, the efficiency of the immune system slowly declines, and the function of the already sensitized B cells is going to decline as well. And the person usually does not have as many antibodies, even to organisms that actually like stimulated their immunity. So revaccination or boosters are more important in older adults. The immune system's normal functions cause transplanted organs and tissues to be rejected. We talked about that, right? Immunosuppressive drugs are used to manage autoimmune diseases and to manage transplant rejection. Autoimmune disease is a condition where a person's immune system sees some of their own cells as foreign and develops immunity against their own cells. Inappropriate immune reactions are sometimes triggered by infection or inflammation in this area, but the actual cause of autoimmune disease is not well known. Management of autoimmune disorders depends on the organ or organs affected. Traditional anti-inflammatory therapy helps manage rheumatoid arthritis and most other autoimmune disorders. There's other anti-inflammatory drugs that we just talked about in chapter 10. This includes like your corticosteroids, NSAIDs, and DMARDs. Thankfully, those are all on the same test. So even though it's repetitive, they're all on the same exam. And then we have direct-acting monoclonal antibodies. Okay, monoclonal antibodies are a type of biologic drug composed of antibodies produced by mouse cells or a combination of mouse and human antibody producing cells, and the target is specific proteins that cause tissue damage. All direct-acting monoclonal antibody biologics are used as drug therapy for autoimmune disorders. These are all parenteral. So the intended response is to reduce inflammation, produce the autoantibodies, reduce the symptoms of the autoimmune disorders, delay or reduce tissue destruction, and improve the quality of life. Common side effects are injection site reaction. We talked about that with all injections, right? Headache, fatigue, flu-like symptoms, and also maybe some GI effects. And since we are suppressing the action of our immune system, our adverse effects include an increased risk of infection, especially TB or hepatitis. So the patient has to have a negative TB test before they initiate this therapy. Other adverse effects are hypersensitivity or allergic reactions. So the patient has to be monitored for 30 minutes to an hour after they get it. So before and after, well, before we want to ask about a previously positive TB test, history of hepatitis. Okay. We want to know if they are pregnant or using reliable contraception. We want to monitor liver function and rotate injection sites. That's kind of important. Anytime that you're giving multiple injections, you don't want to do it all in the same area. And again, since they are reducing the immune system action or activity, we want to avoid crowds and people who we know are ill. Monitor for symptoms of infection. We're teaching them how to self-inject if they're going to be doing this at home. Teach them about the signs and symptoms of allergic reaction. They're also more likely to develop, or more at risk, I shouldn't say likely, more at risk for developing different types of cancers related to the immune suppression. So make sure that they follow up with their routine cancer screenings. These monoclonal antibodies are not recommended in late pregnancy or for nursing moms. Okay, more talk about transplants. I apologize, guys. I know that this version of the textbook kind of goes back and forth a lot. So sorry. So for many decades, it's been possible to remove a diseased or non-functioning organ from one patient and surgically replace it with a healthy organ from another person, right? Successful transplantation requires that the recipient's immune system is suppressed because we don't want to prevent their body from rejecting and destroying that transplanted organ. Yeah. This is 22. It might be a little different because I added that picture. There you go. Because some drugs cause severe immunosuppression and patients can die from infection. An episode of acute rejection after an organ transplant does not automatically mean the patient will lose the new organ. It just means that we have to go into therapy or like treatment for it. So we use corticosteroids, DMARDs, and immunosuppressants. Corticosteroids suppress the bone marrow production of white blood cells and inhibit that immune response. They cause a general immunosuppression. They can greatly increase the person's risk for infection. DMARDs reduce the progression and tissue destruction of the inflammatory disease process. And immunosuppressants target cells that cause autoimmune diseases and rejection. Calcineurin inhibitors prevent that first phase of T cell division by forming a complex that inhibits calcineurin. Calcineurin normally promotes the expression of genes, so that would allow T cells to divide and be activated. With less calcineurin around, the T cell activation and cell division is significantly reduced, so there's less damage to the transplanted tissues and organs. Azathioprine interferes with DNA and RNA synthesis. And selective immunosuppressants selectively target immune system cells and products responsible for that rejection. I think that was on the last slide too. So the intended response here is for the transplanted organs to continue normal function. So we give these once we notice that there's a potential issue. Okay, and the patient retains enough immune function to prevent a serious infection. All selective immunosuppressants cause some degree of immunosuppression and place the patient at increased risk for infection. Most of the drugs are not given to a patient who has a systemic infection already. The most common side effects for all these drugs are GI disturbances of all different types and a variety of skin rashes. Sirolimus and everolimus elevate cholesterol levels. The most common side effects of the calcineurin inhibitors are hypertension, elevated cholesterol levels, and hyperglycemia. And cyclosporine causes lots of patients to have gingival hyperplasia. What is that? Okay, hyperplasia of the gingiva. Okay, like inflammation of the gums. Yeah, gingivitis, but like overgrowth, not like swelling. Like there's more gum tissue rather than swollen gum tissue. Does that make more sense?
Yeah.
Okay. Adverse effects, they're at risk for serious bacterial and fungal infections, suppressing their immune system. Also at increased risk of cancer development. Azathioprine and calcineurin inhibitors can cause liver toxicity and liver failure. Calcineurin inhibitors can also cause electrolyte imbalances, especially potassium, phosphorus, and magnesium. The risk is higher for the drugs that are taken long-term, including, the other antiproliferatives and calcineurin inhibitors. So before we give these anti-rejection drugs, I want to know the possible drug reactions. So I want to know their entire drug list, including anything over the counter, any herbal stuff. Okay, I want to know if they have a liver problem. Afterwards, I want to regularly monitor their blood cell counts. Monitor for infections. Check daily for yellowing of skin. Monitor electrolytes. Some stuff to note here for you as someone that might be giving them. Use PPE. What do I mean by PPE? Yep, personal protective equipment. Use PPE when you prepare and administer these drugs to prevent exposure. You do not want exposure to these. Stress to your patients the importance of immediately reporting any indication of infection to the prescriber. Okay, remind them to check with their prescriber for which types of vaccines they should receive. Also, teach them to monitor for yellowing of the skin or eyes, darkening of the urine, or lightening of the stools. These are signs of liver toxicity. You should also, along with anticholinergic side effects, you should also have a tabbed thing that says signs of liver toxicity, because lots of drugs cause signs of liver toxicity, and you'll want to refer back to that. Also warn patients to avoid drinking alcohol or using Tylenol or acetaminophen when they take these drugs. These are contraindicated in pregnancy and lactation. So if somebody should not be taking these during pregnancy or lactation. And if they are potentially able to become pregnant, they should use 2 forms of contraceptives. Yeah. Acetaminophen. So acetaminophen is really rough on the liver. So if I'm giving something that is already really harsh on the liver, I don't want to add to that. So that we don't reject a transplanted organ. A lot of drugs have really harsh side or adverse effects, but the risk of not giving it would be organ transplant rejection. If we reject a transplanted organ, then what happens? Yeah. So we risk that potential liver issue to prevent potential death. And I know liver issues can lead to death. So it's kind of something that we just very closely monitor, and we have to kind of like balance the scale.
It's kind of like pick your poison.
Yeah. I mean, really it is. Unfortunately it is, but a lot of our drugs have lots of bad effects potentially, but the other bad effect if we don't take them is potential death. So okay, so acute transplant rejection has two mechanisms. It's antibody mediated, resulting in vasculitis and blood vessel necrosis. Or the T cells start the inflammatory response in a new organ. Drug-wise, we give general anti-rejection drugs at higher doses, because you're going to be on an anti-rejection drug forever, but we'll give them in higher doses, and then we use those monoclonal antibodies. Adverse effects are that they can cause electrolyte imbalances, serious allergic responses, and anaphylaxis. An episode of acute rejection can be stopped if we use appropriate measures, okay? And we start it quickly enough. Let's see. Okay, so that's all I have for this chapter.